بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is the third lecture in the sector of imaging of the shoulder. We have finished the normal anatomy and technical aspects. Then we discussed the rotator cuff injuries and the impingement syndrome. Then now we are going to discuss the instability and the slab injuries. As I have discussed before that the glenoid labrum is evaluated in the coronal images as regarded the superior and the inferior labrum, and in the axial images as regard the anterior and the posterior labrum. Then the labrum is usually triangular in shape and is of low signal in all pulse sequences, as you can see here. Shoulder instability means that there is some sort of dislocation of the shoulder, which is most commonly anterior dislocation and less common the posterior dislocation. Then the anterior dislocation represents about 95% of the instability, while the remaining are in the direction, the posterior direction. Then we assess the glenoid labrum and the glenohumeral ligament, which are responsible for the anterior instability in the axial images, looking for injuries of the anterior glenoid labrum. Then one point to be mentioned is where to evaluate the anterior labrum for tails. The most suitable site is the whenever you see the subscapularis tendon, then you look posterior to it, then you see the triangular configuration of the labrum. But if you go upward, and you know here that you cannot see the subscapularis tendon, and you feel that the anterior labrum is torn, and this is known as the sublabral foramen. There is a foramen between the anterior and the superior labrum. Sometimes in some patients you can see this foramen. So many of the radiologists may mistake this or misinterpret this as a labral tear, which is not, and this is known as the sublabral foramen. Then if you want to see any abnormality in the anterior labrum, please go to the level where you can identify clearly the tendon of the subscapularis muscle. Then the first lesion which affects the glenoid labrum, which is commonly seen in the clinical practice, this is the Bankert lesion. And Bankert lesion means injury of the anterior glenoid labrum. Here you can see the posterior glenoid labrum, while the anterior one is not identified. Its site is occupied by granulation tissue, hemorrhage, and contusion secondary to trauma. And you should know that this lesion does not occur spontaneously, and it needs a history of trauma and also history of shoulder dislocation. Then in the axial image, you evaluate the anterior labrum at the level of the subscapularis tendon. Sometimes you may use the MR arthrogram, which will clarify these lesions and display them in a better way than the conventional MRI. And here is the subscapularis tendon, our anatomic landmark. This is the anterior labrum, which is separated from the glenoid part of the scapula. This is the posterior labrum, and you remember from the anatomy that this is the middle glenohumeral ligament, which is located between the subscapularis tendon and the anterior labrum. Then this gloom means that refers to glenolabral ovoid mass, which is simply formed by the disrupted anterior labrum. And this is what we call gloom, let's say that, but this is rupture or tear of the anterior glenoid labrum, which is separated from the glenoid part of the scapula, and this is the subscapularis tendon, and this is of course the middle glenohumeral ligament. And sometimes whenever you look to MRI, you cannot identify the anterior labrum separable from the glenoid. And that's because its signal is no more black. Because of the post-traumatic hemorrhage and contusion, the signal of the labrum will be of relatively high signal, and even you cannot identify the labrum at its site. And this means that you are dealing with Bankert lesion with injury of the anterior glenoid labrum. Then if the anterior glenoid labrum has been torn, as well as its bony part, or the part of the glenoid which is attached to the anterior glenoid labrum is also fractured, then you call this an osseous Bankert lesion. Osseous Bankert lesion can be diagnosed by CT, can be diagnosed also by MRI. Whenever you see that there is a missing part or a fractured part of the glenoid, part of the scapula, associated with injury of the anterior glenoid labrum. And in this example, you can see the rupture of the anterior glenoid labrum together with the related part of the glenoid bone. And this is known as osseous Bankert lesion. In glenoid labral avulsion, or what's known as the Bankert lesion, whenever the glenoid labrum is avulsed from its site, and you call this Bankert lesion, as I have said. And this may be associated with bony deficiency of the anterior glenoid, with large anterior capsular stripping and redundant inferior glenohumeral ligament. Then one of the associated injuries with Bankert is what's known as the Hill-Sachs deformity, and this is a groove or defect in the posterolateral aspect of the superior part of the humeral head, and I will explain its cause. Then can you diagnose osseous Bankert lesion from the plain X-ray? Sometimes you can do so if you can see that the anterior inferior glenoid labrum is disrupted, as well as the associated bony component. And here in the MRI, you can see the defect in the bone, as well as the rupture of the anterior labrum compared to the posterior one. The anterior labrum and its side has been replaced by an area of intermediate signal in the T1 and T2 weighted image, denoting granulation tissue. Then this is the Hill-Sachs fracture, which is commonly seen in cases of anterior dislocation associated with Bankert lesion. Whenever the humerus is dislocating anteriorly, then its postero-superior aspect will be indented by the sharp glenoid edge, and this will result in a defect, and this defect will appear in the humeral head posterolateral, as we can see here. And in many of the literature, they consider this fracture as a pathognomonic finding of Bankert lesion. This is a beautiful CT example of Hill-Sachs injury in the axial and in the sagittal reformatted image, and you can see how sharp the glenoid part of the scapula, which is indenting and compressing the head of the humerus along its posterolateral aspect. Then in this example, you can see that the anterior labrum is torn, and relatively high up in the sections, you can identify the associated Hill-Sachs injury as a shallow or deep groove in the posterolateral aspect of the superior part of the humeral head. And this is Bankert lesion. You can see the anterior labrum is torn, and relatively above this level, and you can see the Hill-Sachs injury. This is also an example of Bankert lesion with Hill-Sachs deformity. Here, the posterior labrum, which is intact, and anterior labrum is replaced by this area of granulation tissue and the hemorrhage. You cannot identify the anterior labrum, and if you look above in the sections higher than this level, you can see the Hill-Sachs injury along the posterolateral aspect of the humeral head. And you have to discriminate between Hill-Sachs injury and the fractures of the greater tuberosity. there is no overlap, of course, between both conditions, since the greater tuberosity is anteriorly located while the heel sacs injury is posteriorly located. Then it is a better technique to evaluate the heel sacs and greater tuberosity fractures in the axial images, so you can easily separate both. And this is an example by plain X-ray of a fracture of the greater tuberosity, and here is the heel sacs deformity in the superior lateral aspect of the humeral head. In the coronal images, there may be some overlap in the discrimination, but in the axial images, you know that the greater tuberosity is anteriorly located while the heel sacs deformity is posteriorly located. Then this is an example of greater tuberosity fracture. You see the fracture line, and of course you know that the three muscles insert into this greater tuberosity, which are the supraspinatus, infraspinatus, and teres minor. Then whenever fractures involve this tuberosity, there may be injury of the one or more of the tendons inserting into the greater tuberosity. Then we came to a second lesion which affects the anterior labrum, and this is known as Bursa's lesion. By Bursa's lesion, we mean that the base of the anterior labrum is torn, but the labrum is not displaced. Of course, the periosteum connecting the labrum to the scapula will remain intact. And this is an example, diagrammatic example. You see the anterior labrum is separated, it's minimally displaced, or even, as you can see here, not displaced. And this lesion is usually post-traumatic, and there may be a history of shoulder dislocation. One of the important issues is whenever you are going to evaluate labral injuries, you see the injury at the base of the labrum, and you don't see the injury at the apex. The apex is freely mobile and cannot be injured easily. Then whenever you see abnormalities in the apex of the labrum, you know these are normal variants, like the cleaved or the serrated labrum, but injuries of the labrum will affect its base, which is fixed. And this is an example of Bursa's lesion, and here you can see that the anterior labrum is separated and the base contains a fluid signal, but the periosteum is intact and the labrum is not significantly displaced. Then you are dealing with Bursa's disease, Bursa's lesion. And then the third one, which affects the anterior labrum, is known as ellapsa, and this ellapsa means anterior labroligamentous periosteal sleeve avulsion. That's to say that the anterior labrum has been torn, it is displaced more medially while the periosteum is still intact. Then whenever you see a lesion like this, and you know that this is ellapsa or anterior labroligamentous periosteal sleeve avulsion. This is an example. The anterior labrum is torn, it is displaced medially while the periosteum is still intact. Of course, you may appreciate that these lesions are difficult to be evaluated without the help of MR arthrogram. Also, if you see this appearance, you consider ellapsa as well. If the labrum is torn and is displaced medially, and whenever it is still in contact with the scapula, you assume that the periosteum is still intact. Then there are the three essentials for diagnosis of ellapsa, which are torn anterior labrum, medial displacement of the labrum, intact periosteum connecting the labrum to the scapula. Then we have three lesions affecting the anterior labrum: Bankert lesion with total separation of the labrum as well as the periosteum, and it may also separate some of the bone of the glenoid. Then you are dealing with osseous Bankert lesion. Then Bursa's lesion means that the labrum is torn, it is not or minimally displaced while the periosteum is intact. The ellapsa lesion means that the labrum is torn, it is medially displaced, and the periosteum is still intact. Then the posterior dislocation represents about 2 to 4% of the shoulder instability, and this means that there will be a tear in the posterior labrum, displacement of the humeral head posteriorly, and you got the reverse of the heel sacs. You remember the heel sacs is in the posterolateral aspect of the humeral head, and this is in the anteromedial aspect of the humeral head. You get an impression due to the impingement of the sharp edge of the glenoid bone on the head of the humerus. And many times, because this will require a significant traumatic force, many times you got also injury of the anterior glenoid labrum. Then you got in the same case a Bankert lesion and the reverse of Bankert lesion. You remember that this is the tendon of the subscapularis muscle, and this is the middle glenohumeral ligament. And this is an example of the reverse of Bankert. You see the humeral head is displaced posteriorly, and you can see the groove in the anteromedial aspect of the head of the humerus, and the anterior labrum is more or less intact. And this is also an example of reverse Bankert lesion, which is a relatively old injury, where you can see the development of bony sclerosis and pseudocystic changes in the groove defect in the humeral head. Then we came to a lesion which is let's say similar to that of the Bursa's disease, Bursa's lesion, but in this injury there is some injury of the anterior glenoid labrum, and the injury will extend to affect the articular cartilage of the glenoid part of the scapula. Then you are dealing with this lesion, which is known as GLAD lesion, and this GLAD lesion represents that there is injuries of the anterior labrum as well as the articular cartilage of the glenoid part of the scapula. Then you can appreciate this when in this MRI, and this is injury of the anterior labrum, and the injury is extending into the articular cartilage. This is the articular cartilage of the glenoid part of the scapula, and this is the extension of the injury as this drawing shows. Then we came to the one of the important issues, which is the biceps labral complex. And you know that the biceps tendon, the long head of the biceps, will pass into the bicipital groove, will course above the head of the humerus to insert at the base of the superior labrum. Then we have to say that the superior labrum may have three normal appearances on MRI. And this is the usual appearance, which is the labrum is firmly attached to the glenoid part of the scapula, while here you can see a small sulcus which is normal between the labrum and the glenoid part of the scapula, and the sulcus may be relatively large, as you can see. All these are considered within normal. And this is the sulcus, this is the superior labrum, and this is the sulcus which is passing below or at the base of the superior labrum. Then this is important to differentiate labral tears from this normal sulcus, as I will mention. And as I have mentioned in the anatomic section, whenever you want to see the whole course of the tendon of the long head of the biceps, you should inject contrast media and do MR arthrogram. Then in the coronal images, you'll see the tendon of the long head of the biceps crossing over the head of the humerus to insert at the base of the superior labrum. Then the slab injuries mean that you are dealing with lesion in the superior labrum and may involve the biceps tendon as well. Then hence the name superior, labral, anterior, posterior. Injuries anterior and posterior relative to the tendon of the long head of the biceps. Then if the injury is extending into the tendon of the long head of the biceps, you got different staging and different grades. Then we have more than one lesion affecting the superior labrum, which are classified as slab injuries, starting from type 1 up to maybe type 18, for example. Then these are the types. Type 1 means that you got some abnormality within the superior labrum or at its base, but this abnormality is extremely limited to the triangle of the superior labrum. Type 2 means that the base of the superior labrum has separated from the glenoid part of the scapula by a distance from 2 to 3 millimeter, and this distance is occupied by fluid, not by intermediate signal similar to the sulcus, for example. Then type 3 means that you got two pieces of the superior labrum, and you see this tear that has separated part of the labrum. And type 4 means that the tear has passed into the tendon of the long hand of the biceps. Then abnormalities within the labrum itself, within the triangle of the labrum itself, will be considered as a slap type 1 injury. But if the base of the labrum has detached for a distance more than 2 to 3 millimeter, and this distance is occupied by fluid signal, then you consider a slap type 2. Then this is an example of a slap type 2, and you see there is fluid signal at the base of the labrum, which is separated by this distance from its attachment to the glenoid. Then if the labrum is now two separate parts, you can see a separate part and another part, then you consider this as slap type 3. Then this lesion where the slap type 3 will extend into the tendon of the long head of the biceps will require MR arthrogram for better diagnosis. Then I mentioned that we have many types of slap injuries, but actually these 4 types are enough to be known for those who are practicing general radiology. But those practicing the musculoskeletal imaging will know more in the range of 7 types of slap injuries, and those who are handling only the shoulder will know about 12 types of slap injuries, and those who are concerned only in the labral pathology will know the 18 types of slap injuries. Then we came to the final issue here, which is the glenohumeral ligaments. And you remember, the inferior glenohumeral ligament will form the axillary pouch. The ligament, when the joint does not contain fluid, will be collapsed and superimposed on the inferior labrum to form this rounded black shadow, which is the combination of the inferior labrum and the inferior glenohumeral ligament. But if there is effusion in the joint, or you introduce fluid or contrast within the joint doing an MR arthrogram, then you can distend the axillary pouch and you can see the inferior glenohumeral ligament separable from the inferior labrum. Then there is a well-known injury which is known Hagel, meaning that humeral avulsion of the inferior glenohumeral ligament. And this is the inferior glenohumeral ligament. When it is avulsed from the humerus, it is known Hagel. And when it is avulsed from the glenoid, it is known as Gagel. Then Hagel means that avulsion of the inferior glenohumeral ligament from its humeral attachment, which is more common. And if the ligament is avulsed from the glenoid part of the scapula, it is known as Gagel. Normally, the inferior glenohumeral ligament will form a figure U, but if it is injured, it will appear like the figure J. Then you can see here, this is an injury. You cannot see the inferior glenohumeral ligament, and if the joint contains fluid, you will see the fluid coming from the axillary pouch into the soft tissues in the axilla. This is the normal appearance of the inferior glenohumeral ligament, and this is the rupture of the inferior glenohumeral ligament from its humeral attachment. This is the J configuration, and you can see the site of the tear of the ligament. Then avulsion of the inferior glenohumeral ligament, as I have said, will lead to leakage of the fluid from the joint into the soft tissues within the axilla and around the subscapularis tendon, as you can see here, and also in the axial image. Then you remember that I have mentioned that whenever you see the inferior glenohumeral ligament is very short and very thick, and you think of adhesive capsulitis or what's known as frozen shoulder. I have mentioned also that the normal thickness of the inferior glenohumeral ligament is in the range of 4 millimeter. Then if you see that the ligament is more thicker, then you are dealing with this pathologic entity, which is known as adhesive capsulitis. The middle glenohumeral ligament is seen in the axial images between the subscapularis tendon and the anterior labrum, and this is the middle glenohumeral ligament. In the sagittal view, you can see the whole or the three ligaments whenever you have injected contrast media inside the joint. Then this is the posterior labrum and this is the anterior labrum, and this is the subscapularis muscle. You remember that the middle glenohumeral ligament lies between the subscapularis and the anterior labrum. This is the anterior labrum and this is the subscapularis. Then you can see the whole course of the middle glenohumeral ligament. And you remember the superior glenohumeral ligament is usually attached to this area, and you can see it as a fine line in this example. Then one or the only pathologic entity you can diagnose after rupture of the ligament is this pivot complex. Pivot complex means that the middle glenohumeral ligament is cord-like, is very thick. And you see, this is the subscapularis tendon, and this is the middle glenohumeral ligament, and here is the anterior labrum. In this example, the middle glenohumeral ligament is very thick, and this is known as bifid complex. Many consider this as a normal variant, and others may refer this finding as the only explanation for shoulder pain if the MR images did not show any other abnormality. Commonly, this bifid complex is associated with absence or hypoplasia of the anterior glenoid labrum. Compare this labrum with the posterior labrum, which is more evident. And the biceps tendon is evaluated mainly in the groove and in the axial images for any abnormalities of the biceps tendon. If you want to see the full course, then you should have an MR arthrogram. You will see the tendon passing through the bicipital groove, crossing above the head of the humerus to insert at the base of the superior labrum. And in the axial images, you see the groove, which is located between the lesser tuberosity and the greater tuberosity. Then you can see the biceps tendon. Sometimes you got a splitting normal variant or normal splitting of the biceps tendon into two parts, and this can be easily discriminated from the traumatic splitting of the biceps tendon by the absence of history of trauma and absence of evidences of trauma in the images, like bone marrow contusion, soft tissue edema, and the hemorrhage around the affected tendon. And you remember that one of the common abnormalities of the tendon is to be dislocated together with injuries of the subscapularis tendon. And you know the intimate relation between the subscapularis and the biceps in the groove. So if the subscapularis tendon is torn, sometimes it will result in dislocation of the biceps tendon outside the groove, as you can see in this example. And then this is also another example of biceps tendon injury and displacement of the biceps tendon outside the groove. You see here, this is the site of the biceps tendon. This is of course not the anterior labrum, because the anterior labrum is clear here, and this is the posterior labrum as well, you see here. Okay, then partial tear or complete rupture of the biceps tendon means that you cannot see the tendon in cases of complete rupture. Instead, you will see fluid signal at its anatomic site. But if you see the tendon which is containing abnormal bright signal within its substance, this means that the tendon is partially torn. And if, as I have mentioned, if you search in the notch and you cannot see the tendon, and you see instead an area of intermediate signal which represents hemorrhage and contusion, and sometimes the fluid signal also, and then you cannot see the tendon, then you assume that it is totally torn. Then if you ask about what are the values of MR arthrogram, I think, in my opinion, that MR arthrography in the shoulder is essential for evaluation of partial tears of the supraspinatus tendon, especially the articular surface tear, and also is very helpful in evaluation of labral tears, considering the Bankert lesion, the Persis lesion, the GLAD, and the Alapsa lesion. Also, is very important for evaluation of Hagel. You want to send to distend the axillary pouch to see this ligament and if it is disrupted from the humeral attachment or the glenoid attachment. Also, it's very helpful in evaluation of injuries of the superior labrum, particularly when these lesions extend into the tendon of the long head of the biceps. Then how to interpret the images of the shoulder by MRI. This is just a recommended approach if you want to go through this. Okay, if you have another idea, it's good. Then, in my opinion, you should start by the coronal images in the T1 and T2 weighted image. Then you evaluate the lesions and the structures which are clearly seen in this particular images, including the supraspinatus tendon, the infraspinatus tendon, the superior labrum, and the acromioclavicular osteoarthritis. If there is joint effusion, what about the subacromion subdeltoid bursa? And finally, you have a look on the inferior glenohumeral ligament. The axial images are very good for evaluation of the stability, especially anterior and posterior dislocation, evaluation of the subscapularis tendon and the infraspinatus tendon as well, evaluation of the biceps tendon in the groove, looking for heel sacs injury, which is one of the pathognomonic features of Bankert lesion, and you can identify here the middle glenohumeral ligament between the subscapularis tendon and the anterior labrum. The sagittal images are very important for evaluation of the acromion shape, the four shapes you know, the acromioclavicular joint for osteoarthritis and so on. Then the sagittal images are very essential for evaluation of the coracohumeral ligament, the coracoclavicular ligament, and also evaluation of the rotator interval lesions which are located between the supraspinatus and the subscapularis tendons. I thank you very much. Alhamdulillah Rabbil Alameen. Wassalatu wassalamu ala Sayyidina Muhammad wa ala alihi wa sahbihi wa sallam.